what we've heard today. Then I plan to come back down to more this end of the table and to ask principally the ethicists and the lawyers amongst us, but obviously other contributors as well. But really, if we can resolve or come to a view on the list of questions that we have, which are primarily, as you know, ethical questions. So that would be my plan. So if I can first of all ask, are there any views from the patients or lay people or nurses who gave us the contributions at the beginning? Would you like to add anything or comment on what's been discussed? Yes.
So what I'd like to just perhaps say, which some people have already said, is from a patient's point of view, really some more information ought to be given. Because in my case, what wasn't really right with my first eye when I had it done, it's not that there was anything wrong with the procedure or whatever the error that occurred regarding the lens that was put in my eye. If I was to have both eyes done, I would like to have the information, if I had to have them done together, I would like to have the information that, as my colleagues have sort of said, when they do that, the whole pack or whatever procedures used at the time of the surgery is from completely different for one eye than it is for the other. I think that might encourage patients a little bit more to agree to having the two eyes done if they knew, okay, if something did go wrong, it's not likely to happen to the other eye because, you know, there's all these additional precautions being taken.
Thank you. Thank you. Yes, I think that's a very valid point. Any other?
Thank you. Now, as a patient, I feel that we need a lot of information so that you can make an informed decision about what is best for you as an individual. You can choose the immediate sequential or you can choose the delayed, depending on your own situation. So I think information is everybody's echoed. Is very important, and also the time you are given to comprehend it is crucial, because some people are quick thinkers, some people take a lot of time. So if we put patients first, not the views of the surgeon, not the fear of the complications, but what does the patient want, to me I think is critical.
Thank you.
I'll just back that up and say I think informed consent is what we're really talking about all the way through this, isn't it? And making sure that everybody has the information they need. And interestingly, you're talking about the Egyptian bit where I'll go with what the doctor says. That certainly isn't the way we want to move forward here, is it, clearly?
Can I ask, on that subject, if patients say to us, as they do sometimes, that they don't want all this information and you're trying to explain risks and to them, and they say, look, you're the doctor, I just want you to tell me what's the right thing for me. Are patients allowed to consent to not having information? Is that a choice they're able to make, or are they not able to make that choice? Do we disallow them to decide that? I don't know.
I think that's a very important question to ask the ethicists down here in a minute. So I think we'll just, if there's any other contribution before we do that.
With regard to the refractive errors and things like that, bilateral, sequential, for me personally, you wake up with what you've got. You don't know any different. And as long as it works, it works. So I disagree with the gentleman over there that's left about tailoring lenses. And I have known people who've had a cataract operation on a Friday and gone back for their second one on the Monday. Now, if all the risk factors are the same, then with that shorter period, you'd still have the same risk factors. So to have them separated in such a small time frame surely wouldn't make any difference. And I do think sometimes it's a bit of a postcode lottery. If you have a surgeon that in your area that can offer you this procedure, why is the consent so small for consultants to do this procedure for people that do want it? And the other thing I have is that people of certain ages will, on the ethical issue, will just say, "Doctor, you choose," and nod their head. Yes, that needs doing, you do it. But expectations from maybe the younger age groups are totally different, and they do need a lot of input, a lot of information, and are willing to accept it and want to know it. And I think it's our responsibility to fulfil that and manage the expectations for them as well as others.
Thank you. Thank you. Very good point. Anything else before we perhaps address these ethical questions? So can we pick up on that first question? Yes, Pete.
Shall I make a quick comment about the patient refuses to give consent? If we think that what's underlying your respect for autonomy, it's respect not for autonomy, but respect for the patient, for the person. So part of respect for the person is to say, okay, if you don't want to make the decision, that's fair enough. That's also respecting their dignity. So we do say, you don't have to make a decision. When you make a decision in their best interest, but obviously involving as many people as possible. And then you write it all down, and document everything.
I think the key thing probably is documentation. Is whatever you do, that you need incontrovertible written evidence. Sorry, Chris.
I was just going to say that Rebbe here had not a chance to talk yet.
I'm so sorry. Yes.
Sorry, I wasn't sure I want to, but now you haven't given me much options.
As long as we document that you don't want to.
Okay. So, just a few observations, and some might be completely irrelevant. I have no professional medical degree or any of that, and even my practice as a rabbi is more or less limited to teaching a certain age group, certain rabbinical studies. So I don't actually act as a rabbi anywhere. But I do have a lot of experience in working with the medical profession. We actually lead a charity. I'm the director of a charity that we act as advocates, and we do referrals for patients. So when they call us when they're really stuck, we try and keep abreast of what's going on in the medical profession and find out from insiders who is best for this particular complex issue and refer them straight to that center rather than going through the system, and until they'll get there will take a few months and they lose valuable time. We try to know what trials are around. So that's actually how I got to know the professor. And in the first place, actually, we referred them a few patients recently. So I just wanted to ask a few questions. Number one, the patient mentioned that about consenting and explaining different options. I think consent post-Montgomery, that will be a basic. It will actually be a misconduct if you haven't explained to the patient that there is a different option that might be sensible even for some people. You could be sued for doing that. So if that was the experience you have had, and nowadays I think that would be just a misconduct. It's against the law. And so if we are debating, switching practice for something that might make sense, but even for some people it doesn't make sense, we would still be obliged to tell the patient, that you might feel that option B is more sensible for you, although we think option A is the right one. The other thing, when we mentioned that consultants are expected to be teachers nowadays, it's true. You expect them to teach the patient why and what the options are, and suddenly the patient wants to understand the pathology and what's going on. And not everyone is up to getting it within a few minutes. And on the other hand, I gather that you as doctors would be more frustrated than the patients, that actually you don't have the time in the NHS to give that level of attention to the patient. But on the other hand, the expectation is that you will be able to deliver that education to the patient. So I don't know exactly how, from your side of the table, how you cope with that. But I think the more choice you have, the more teaching you have to be, the more teaching you become. And it always depends on the qualifications of the student, how much they will pick up from your little lesson. That's probably doesn't give you more than 10, 15, 20 minutes with the patient. So that might turn out to be a problem. I also wanted to ask if something does turn out to be a postcode lottery, because there are not many surgeons who are willing, who have adapted to this practice. Is that a reason not to do it? if you feel that it's right and you have the capability of doing it, just because it's not accepted around the country, but it is a postcode lottery, but happens to be that this patient has won the lottery, should they not get their prize, just because there are other people who won't win the lottery. And the other thing is something just as a layman. The gentleman who was on this place earlier on, so sorry I don't know the names, has said there's a genetic predisposition to a problem that would arise from the surgery. Is that something that could be tested prior to surgery, and what's the cost of that genetic test? If the cost of that genetic test is less than what we would benefit by doing bilateral surgery. So let's say doing it bilateral would save you £300, and that test would only cost, let's say, £50 to do that, to test for the genetics. There would be an argument, check all your patients for the gene, and then you make an informed decision if we're going for bilateral cataract surgery or not. Sorry, that's it for now.
Thank you. Thank you. So some good points and some interesting questions. So can I come back down to this end of the table now and perhaps ask you to respond on the questions that we've raised, and then I'm going to go through this list that we've got as well.
I was just going to respond a little to the. Thank you. I was just going to respond a little to the comment on the paperwork, because unfortunately this is going to be quite a philosophical answer. So it's on the one hand, but also on the other hand. So I do apologise there. I think that we need to be very careful about what we say is the most important thing, because the most important thing, as Pierre mentioned, is the dignity and well-being of the patient. Paperwork is terribly important, and I appreciate the point, but I think that that is a secondary consideration to what's in the interest of the patient. So one of the things that's come out quite powerfully, I think, is difference in patient capability to understand and appreciate what it is that they're going through. So that consultation, that consent procedure has to be compassionate and considerate of those varying capabilities. And not to reiterate what I said before, but I think we need to be very careful when we're thinking about how surgeons communicate with what the risks and hazards, but also potentially being considerate of what those extra needs are and how that whole patient as a whole is cared for throughout the consent procedure. So in a way to respect them as a dignified person entitled to proper care and respect their best interests. So on the refusal of informed consent, a consideration is, as just to agree here, taking care to make sure that even if they say, I don't want to make a decision, maybe tell me what you would do. Well, I would do it this way, and being compassionate to what those needs are and considering. I think people have already said to what their family have said as well, or what carers or other people who might be able to communicate with them more carefully in a less intimidating way. So that would be a suggestion that I think.
Thank you. And can I ask?
Can I offer? I was asked for a legal analysis.
30 seconds.
First of all, you've got to decide whether you can do this procedure at all. It's obviously a technical issue of balancing risks and advantages of the procedure. And it seems to me that the analysis obviously stands up to analysis, so it's covered by the Bolam rule. The Belitho test doesn't say that this doesn't stand up to analysis. Chris circulated an article which suggested on a survey that about 15%, I think, 13% or something, of ophthalmologists are doing this. Well, we had a case of De Freitas and O'Brien in the Court of Appeal, which says that a respectable school of thought doesn't have to be a large one, and therefore I have little doubt that we could say that this was Bolam respectable, and therefore you could do it. Unfortunately, once you've got over that hurdle, you immediately find yourself in the small print of whether you should have done it in this case. You take into account circumstances, and I understand the problems of operating on people in Barra. We had about 25 years ago a ship going around the Mediterranean run by a Russian ophthalmologist, Fedorov, called Phlox, And he used to do lots of procedures on people, including a lot of cataracts, and the post-operative care was to push them down the gangplank. And we put a stop to that. Cooling took it on himself as a sort of personal thing, and we did manage to stop it eventually. You've obviously got problems of patient selection, and you've got to be pretty careful about that, and you've got to be very careful about the technicalities of which you did it. The advice from NICE is hedged around with a lot of technicalities and precautions that you have to take. And I would have thought that it was probably easier to get the average camel through the eye of a needle than to prove that you dealt with all of that and that you might well be cruising for a bruising. If you get a post-operative bilateral infection, I think somebody would start asking questions about your wound infection rate in theatres. Is it not likely that somebody had slipped up on the hygiene, somebody for whom the trust is responsible, and so on and so forth? You obviously have to take extreme precautions before you do it. So I'm not saying it's strict liability, but I do say that the issues of patient selection and technical performance will be very challenging if you have a problem. However, as people have said, the real issue here is counselling and preparation of the patient. And the rabbi mentioned Montgomery. Paragraph 85 of Montgomery does say that the patient can opt to be told nothing and say, I leave it up to you, doc. The difficulty about Montgomery is that it was given in 2015 at Concerned Events in 1999, relying on guidance issued by the GMC in 2008. So I have to advise you today on what is going to happen when the GMC next reconsiders this business in 2030. And the one thing that I can tell you is that the bar is going up all the time. I'm so sorry. And that the obligations that the law is imposing on you in communication are getting more difficult and more challenging all the time. Somebody mentioned that patients over 80, yes, they're cognitively impaired, they have 4 comorbidities, they're not interested. That does not mean that you do not take on extra burdens of caution when you take decisions, put yourself in a position to take decisions on their behalf, and I think you would find that more difficult than where you had an enthusiastic volunteer. I think that the issues that the law is going to be scrutinizing in 2030 are not whether you informed someone, not whether the risk was mentioned, but how was it mentioned, where was it mentioned, what steps did you take to ensure that the patient understood it. I entirely understand that from the ethical point of view, it's what happened in the patient's best interest which is most important. The law is concerned, however, with creating the most plausible fictional account of what happened in a past event, piecing together what the evidence suggests happens. And my basic rule of thumb is that if it isn't written down, it didn't happen. And when I say written down, I do not mean some acronym or scribbled terms recording what a doctor said. I mean whether or not there is written evidence that the patient was treated with respect and put in a position to exercise their choice. Somebody mentioned at an interval before the procedure. That's obviously important. It's obviously important it should be outside the context of the clinic where they've just been told that they've got to submit to surgery, which is extremely frightening. Journal of Bone and Joint Surgery 2006, Professor Lemaire collected studies from all over the world of people who have been given information in controlled circumstances, who didn't have complaints, who didn't have claims, and he looked at what they remembered at various intervals, starting one day after the procedure. And the answer was very poor. People do not lay down memory. They do not remember things. When I go into an Italian shop to hire a car, I will be confronted with a load of 6-point that I cannot read, in Italian, which I've never been able to read, written, I know, by some bastard of an Italian lawyer to screw me. Do I sign the form blindly or not? Or do I ask for a translation? The answer is, do I want the car? Why was I there? Of course I want the car. If I don't want to get clobbered by the wife when I come out and say I haven't got a car, I sign the form. And when I go and see a doctor, because I can't see, I want the procedure. And if he's a surgeon, I'm probably expecting a surgical procedure. That's why I am there. And you have got to make records that show that you have discharged your duty and overcome that obstacle and said, slow down, Bertie, I am not offering you a simple, safe bullet which will enable you to walk out of this hospital at the end of this afternoon able to see perfectly in 2 eyes. That's not what medicine is about. You're helping me to take difficult decisions, and you've got to be able to prove that you have done that. And as I say, if you don't do it in my own first language, you're probably going to fail. And if you don't do it in circumstances where I am at rest and confident of my environment, you're probably not going to satisfy the UK Supreme Court in 2030 that you have discharged your duty to do it in the best way possible. And as I've said earlier, the only way you're going to be able to do that is if you can demonstrate that you've redesigned medical services around the patient rather than around the doctor. And you've got to put the patient at the centre, which means making the patient do the work and not try and taking on so much of the burden on the medical shoulders. So in answer, yes, it's not negligent to do it, but you're likely to lose.
If it goes wrong.
If it goes wrong.
Juliet?
I'm not sure I can follow that, Bertie. But I can probably say it a little more concisely. It is absolutely patient-centred. And, you know, what is I repeat what I said earlier, what is a material risk for one patient is not a material risk for another patient. And the lesson, I think, for all of us around the table, patients, not just speaking to doctors, but patients and doctors, is that communication is key. And if the patient understands the doctor and the doctor understands the patient, then the likelihood of medico-legal consequences occurring for the doctor, even if there is a minor adverse outcome, are far reduced.
Thank you. Well, very useful perspective from you. Well, thank you very much. What I'd like to do is to go through the list of questions and hope that we can come to a view on each of them. I hope you've all got that in front of you. It was in your set of papers. That's, and I think we have covered the first question, but I'd just perhaps like to again ask the ethicists just to confirm what factors govern the ethics of immediate sequential bilateral cataract surgery in adults.
So when I perused these before I came here, I was trying to think about the different on the one hand and on the other.
Yes.
And I think from a health justice point of view, I think I was thinking cost on society, the cost saving on the society, but from what Mr. Burton said, that's really not even a factor in this equation. So I think that removes the social pressure on the individual. Even though the individual is the focus of all care, it's within a collective, in a shared pot kind of thought of the individual. So pulling the social back a little bit and focusing on the individual, this brings in really the ethics of, I think, what everyone has been as boiled up to the surface of this brew, which is the individual and individual choice. So I think that's the thing. It's the point of we as doctors, that doctor-patient relationship, ensuring there's a trust there and ensuring that we, the doctors, are not exposing the patients to unnecessary harm, bringing us down into the old school of beneficence and non-malevolence. So I think that's the nub of this really. Once you remove that social justice aspect, and then we're getting into the tricky world of informed consent and all the dark hidden corners of it. So I think that's the bit of the ethics where the rub is of the ethics of this one. I suppose, is it beneficial, or can patients wait 3 months to have the second eye done? And again, I think that's got to come down to the patient, really. That's my
thoughts on it?
Just a question on that, just to clarify what you're saying in the light of Mr. Burton, is it here as well? You know, are we saying that the overall economic thing is really not relevant? Or, you know, are we saying that were one to move, say, strongly in favour of bilateral surgeries and maybe just trying to create a culture in which it was encouraged, partly because maybe you're going to get faster MRI scans for your cancer or whatever? I mean, is that off the table then now, that consideration, or what?
My answer to that is I don't think we've actually modelled it properly, because we've not looked at all the what-ifs. You can easily say, yes, if you do this, you will save 200 quid up front. But we don't know how many people are going to have serious complications or reoperations because the wrong lens went in and therefore it had to be done again. And if, as one day happens, somebody will go blind in both eyes as a result, the cost of that society will significantly, you know, it's £70,000 for a guide dog. You know, that's a lot of 200s. So we have to, if you're going to start arguing economics, you have to do it very well and very thoroughly. I would say the cost effectiveness of cataract surgery is immense compared to pretty well everything else we do, and there are certainly things in ophthalmology we do that are not anywhere near as cost effective as that. So I think the answer is, in my sort of global assessment, is that we haven't done enough to say that it's my gut feeling is it is difficult to say for £200 we've definitely proved that's the only argument that counts. And certainly compared to how much we spend on health, is that £200 worth starting to say to people, really, ethically, that's you really got to come down on the £200 saved side.
And so you throw into that the considerations of the nurses mentioned earlier, you know, it's a lot easier for them, etc., etc., etc. But what you're saying is we can't really make that judgment, really. I mean, those sort of things are not that relevant to the discussion. The fact that it's easier for a doctor normally to do the bilateral thing is really not relevant to
I don't recognise it's easier. I can do one eye or two eyes just as easily.
But you have to prepare the person, you have an extra post-op appointment, you have to get all the implements ready twice, and etc., etc.
I have done bilateral simultaneous cataract surgery in selected circumstances. I've studied it well in terms of having to look through it nice. I still think it boils down to patients' assessment of the risk-benefit analysis in their situation. I mean, I could make it simple for you. Would we be here today if the risk of blindness in two eyes from doing this was 1 in 10? Would we be here if it's 1 in 100? Would we be here 1 in 1,000? Where are we going to start saying we'd actually even be assembling? Absolutely. That's what we're actually talking about. It's slightly more difficult because we don't actually know the risk for bilateral. What it's saying, if it was a risk for one eye was 1 in 10, would we be here talking about having 2 eyes done? If it's 1 in 100, we're actually at that 1 in 1,000 of significant complication that causes severe visual loss in one eye. We don't know what it is for 2. So we are discussing it because we don't know where that risk analysis benefit stops. And I personally don't think we can actually make that judgment for other people. We have to present the best, the limited information we have, and say, what do you want?
We need to encourage more research then, in terms of the overall statistical...
We can, but it is an interesting thing because, and it is, I was interested to hear your comments on the you know, if somebody has got bilateral endophthalmitis, somebody's going to come along and say, was that a fault of the, you know, was that unlucky or was that the thought of the theatre? I don't know quite how you'd answer that. I think we do need to research. One of the biggest problems we've got is that some of the risks we're talking about are very rare. It's probably a 1 in 10,000 now of endophthalmitis. But even that evidence is debated because that is a series, not a randomized controlled trial. And it wasn't even against one drug against another sort of thing. It was basically, we did 10,000 cases, and we all gave them intracameral antibiotics, and they did very well. That's a sort of way that NICE had to do its intracameral antibiotic recommendations. So the evidence is very difficult because the incidence of severe harm is low.
From a national cataract data set last year, I think there was about 50,000 it's published by the Royal College. There was about just over 50,000 operations on the data set, I think, and there was 1 in 4,000 rate of endophthalmitis, I think, was what it was sitting at from that series of 50,000. So if it's 1 in 4,000 and we would only select low-risk patients, so exclude all the diabetics and exclude people with any other comorbidity, then you would hope to get lower than 1 in 4,000, but 1 in 4,000 is your base. So 1 in 4,000 times 1 in 4,000 is 1 in 16 million. The only published estimate of the risk of bilateral blindness, because not all endophthalmitis ends in blindness, it's about 50%. So the published estimate of the risk of blindness set it at 1 in 36 million risk of blindness. But as I said, it will happen because we're doing 500,000 cataracts a year. It might not be this year or next year, but at some point it will happen. And at that point, I think maybe most of us would be happy to lose in court because that patient needs to feel that they have been vindicated. But I think from a societal point of view, again, because of the numbers, it's a non-trivial saving. What our health economist colleague said, if we were to look at a £300 saving per case, and with 500,000 operations, if we said half of them were eligible for the bilateral pathway and only half of them accepted, that still leaves you over 100,000 people saving £300 a go. 100,000 times 300 is £30 million. So, and that's a recurring. So if we move to this pathway systemically, we could be making savings of the order of £30 million, and that's just secondary care. That's not savings to families, to patients who don't have to take time off work, to district nurses who don't have to support people twice at home, and et cetera, to referrals. That's another source of cost. So if we're talking about an order of tens of millions of pounds saving annually, then the fact that there are these rare cases, which it will be, I mean, a £70,000 guide dog is suddenly sounding quite good value, but particularly because that patient would have gone blind anyway,
I would
statistically.
Say the concern I have with that is you are taking a 1 in 4,000 times a 1 in 4,000 and coming up with a 1 in 16 million. That is entirely inappropriate.
It's not appropriate.
You can't do it that way because if you've got an antibiotic-resistant germ on your skin, it will be in both eyes. If you open both eyes, the risk is now become 1 in 1,000.
But the £30 million is not irrelevant, is it? The £30 million saving is massively irrelevant.
I don't think we've got evidence to say. We have no economic analysis, proper economic analysis. We can speculate all we like. And it starts off with what you think the actual risk is.
We need that analysis.
Oh, I agree.
I mean, the commissioner said he wants to save money. You know?
Ultimately, it will come down to patients' perception of risk. I genuinely believe that, and it is very difficult. I agree. We'd like to know what the risk actually is. But the risk, I say, you know, if you said it's 1 in 1,000, and you said you're doing 2 eyes, you can either say that's 1 in 2,000 or 1 in a million. And you can't really justify which of those two figures you're using.
That's also important, but the financial is, I
think certainly from an ethical perspective, that's what that pulls us back a bit out to the social. There is a social demand, in fact, justice, that we, as doctors, distribute our health resources as fairly as possible.
Better targets
I'm not. Ophthalmologists are guilty of quite a bit of, you know, with the old AMD. But I think did I read somewhere that the 2 biggest outlays for Medicare in the States, number 1 is cataracts, the second one is AMD treatments. That's just because they do so many. You know, that's the thing about this, and this is going to only increase. So I think that's from an ethical point of view. I think that's something that pulls us a little bit away in that patient-doctor relationship. But ultimately, the risk there, I think, does have to sit with the patient, I think, because the patient's ultimately going to be living with the consequence. But at least as a profession, maybe we should be offering it as a pathway that patients can slot into. It's something we should be looking at anyway.
Let's say 75% of ophthalmologists choose not to offer this procedure. Is it unethical not to offer it to people who believe that it might be the right choice for them, like the Geographic Considerations or...
Posting lottery question.
Yeah.
Maybe. It's very difficult to say. I mean, one of the things that came up, and it's question 5B, I think, on the original numbering, it's not on the latest sheet, is if people can't get it in their local area, should they be allowed to travel for it? And the thing that popped into my head with that was, well, we've been talking about the risk of travelling for the hospital, to your local hospital is greater than the surgery itself, and that this is a consideration that's worth thinking about. I'm not convinced that that is a consideration that's necessarily relevant to the debate around the surgery itself, because I think that that's outside of the field, or that could be argued to be outside of the field of surgical responsibility. I think that, and I'm not convinced either way on whether this is a procedure that we should be offering, but I think if it is the case that it should be offered, then everyone should have access to it, and that becomes a very different question about access to resources. If it's the case that we might say that people who feel able to do it can provide it, but we can't oblige surgeons to provide it. And it may be the case that we say, well, if you live somewhere, then you can, or we will fund your travel to the place. Or we might say, well, if you live somewhere, then you're lucky, but we don't have enough surgeons to provide it, and we have a procedure which is just as good in your local area, and that's a reasonable response to it, given that we live in resource-constrained circumstances. But
sorry, can I come back on the law? The law does have quite a strong view. First, no doctor can be required to do a procedure that they do not think is in their patient's interests, and should not do so. And if the patient has demanded it, the doctor has a duty to refuse it. It's pretty clear that the advice from NICE is that you should refuse to do it if they're diabetic or various other contraindications. So you can't rest too much on the patient's ability to demand it, and if the surgeon is one of the 75% sitting around the NICE table who does not believe it is right for themselves, I don't think that you can, the patient's right to have the procedure can require the doctor to do it. The patient may practically be able to find surgeons amongst the 17% who do it, according to Chris's registrar survey, and you'll be able to get it, but that's another matter. The patient doesn't have a right to require a doctor to do something they think is wrong, and I don't think we should go away from that or dilute it.
No, I didn't mean to suggest that we should be compelling people to do it. My thought was more that maybe we should be, if there is an entitlement to that procedure recognised nationally through NICE, then maybe that we should fund their travel to a facility where one of the 25% is practicing, but I wouldn't suggest that we should compel someone to perform a procedure that they're uncomfortable, that they don't feel qualified to do. That opens up a whole other,
someone.
Yeah, but there is then the question of whether we should actually pay for someone to travel when there's just as good other services available. But that's a whole other question.
So I think NICE does say that bilateral should be considered for routine cases.
Can I just clarify that? There is a very nice defined NICE speak, and I think we said consider, yes, which is basically means, well, there is possibly some benefit. There is no musts in a NICE guideline, and the strength of the recommendation was at the weakest level because of the difficulty weighing up a firm, a firm. There's a lot of caveats that were identified that meant that it was consider was the appropriate level on the basis of the evidence available, which is a very, very weak recommendation.
Thank you. But nevertheless, it's a recommendation, I suppose.
Yeah.
A weak one, yeah. Juliet, do you want to?
Just a little clarification there. I absolutely got the guideline myself, but I think just remember from a legal point of view, the guideline is a guideline. It's not the law. And in the right cases, for the right patients, it is legal and acceptable for clinicians to depart from a guideline, but they would have to have very clear reasons for doing so. And I'm sure if there was an adverse event with a procedure where a clinician had departed from a guideline, the patient solicitor would be scrutinising that guideline very, very closely.
We are tending to drift to discuss general issues, health, economic issues, offering broader, across the country, postcode lotteries, all this kind of thing. The issue here is also surely the question that in the old days, doctors had an individual contract with their patients. And here we're talking about health systems getting involved in all this. And I personally feel quite strongly, and I think also from the faith ethic point of view, that this is an individual that you're talking to. This is not a person, and this is not an abstract person. This is somebody you're talking to. You've got to talk about the risk there with that person. You've got to talk about the consent there with that person. It's an individual. It's the individual relationship. The guidelines are very useful, and they may guide you along the way. This should be a possibility, as which should be considered and could be considered. That's where we are at the moment. But at the end of the day, what we need to surely be thinking about is what is the best way to actually get the message across at that interaction, and that's somewhat more important than, to my mind, than any of the economic issues. And then you also have to take into account that it's all very well we've got all these statistics and data, but all these statistics and data are excluding the comorbidities, the diabetics, the people with all these complications. They're all excluding those and only looking at the small sector. I found it difficult in some of these, and I think NICE did kind of take into account the fact that a lot of the data looks at the selected group, doesn't look at what happens to all the diabetics who do have the single cataract corrected, and how well do they do, and is there a rate of complications amongst them which might actually be much higher, and might therefore bias us towards single eye because there's a higher complication rate over there. It's all buried underneath that, and you're talking about a doctor sitting and talking to a patient, and potentially a very vulnerable patient, and a person who's very concerned about their loss of vision because it may affect them in all sorts of ways, economically and so on. So, if we're going to come out with some kind of consensus, we do have to kind of put the doctor-patient individually at the center of it, not some of these other considerations.
If we assume that the two processes are economically neutral, there is no financial benefit for the sake of the argument in doing this, and put the patient at the centre of the approach and at the centre of the discussion, and make sure the patient is well informed and then has the option, taking into account the convenience given his or her particular circumstances and the risk, then is there a way forward in that? Then if there are financial benefits, that's a useful little spin-off for the health service. Is that perhaps a more appropriate way to approach this?
I think NICE recognise that there is actually a measurable benefit if it goes well to the patient, because they get their vision in both eyes a little bit sooner than otherwise, and that little bit sooner varies from a few weeks to a few months to sometimes 6 months depending on the unit concerned. So there is an actual measurable benefit. The question then becomes how much does that benefit weigh up against the risk that that patient perceives? Is it it's about the whole weighing up for the individual, the convenience, the benefit, the risks, and you cannot make a blanket decision for an individual because everybody has their own ideas of risk. I've got patients who are nearly blind, and I say, unfortunately, there is a risk you could lose the sight, and they will practically run away from the clinic. There are patients who've got excellent vision, who've got a little bit of a problem, who you're sort of thinking, do you really want this? And yes, they really do want it. But that's their choice.
So I think, sorry, Father, we're not talking about individual patients here. I think, should we try and answer these questions because they're generic questions? Otherwise, we would have spent 3.5 hours sitting here and not really come to any conclusions. Please. Sorry, Father, what were you going to say?
I was just going to very briefly say, as a matter of principle, I don't think we want to say that the high-level decisions that are taken are not relevant to the individual. In fact, I think it's quite the opposite. I mean, you have to take high-level decisions. You have to have economics, maybe not so much in this area. And they have a profound effect upon the individual and the vulnerable. And in a sense, one of the things that certainly the Catholic social teaching is saying in its preferential option for the poor is that those high-level economic decisions that affect everybody, you must take account at that level of the individual vulnerable person. Because if you don't at that level, they're going to be discriminated against. If you just take a broad quality of life thing, or you just take a broad economic thing, the old and the disabled or whatever, are not going to get their due. They should be taken more account of at the overall level. Otherwise, they're just going to be treated like anybody else, which they shouldn't be. And maybe not on the individual level. I mean, I agree with everything's been said about the patient-doctor, and there's a lot of wisdom about that, and I'm not denying that, but I just think the overall economic thing is equally important to take account of the poor and the disabled and the vulnerable.
Did you consider the idea that Steve Vernon was telling us, that the advantage of doing it at intervals is that when you do the first procedure, you sort of get your eye in, so you get a more accurate lens for the next time?
That is actually one of the exclusion criteria that tends to dominate the current evidence, is that there are certain patients whose eyes are slightly outside the standard shape who are more likely to have a lens implant that may not be entirely accurate. And in fact, elsewhere in the guidelines, you will find a recommendation on how best to deal with the situation should that happen in terms of your choice of your second
It's only
lens.
that subgroup of patients.
Yes, absolutely. So I think, I mean, if somebody comes to me and says, could you do both eyes at the same time? And I say, I can. There are unquantifiable additional, risks you have to think about. If you want, and I can give you my best assessment of what those risks are, but they are, in some respects, guesses because we haven't got sufficient data. If somebody wanted that done, I'd be very happy to do it. But I'd have to be keen to understand that they know and they have really thought through what they're asking. So I'm not saying you shouldn't have it done. I think it depends on the patient. And as I said, around the table, a quarter of the people around there wanted it, and if they came to me and said, I wanted it done this way, they've had a lot of opportunity to weigh up as best we could in nice. I would have done their eyes for them. It's not a right or wrong. I do think the economic value or otherwise is not great, because I could point you at many, many aspects of the health service which we should really be looking at the economy. I could tell you tomorrow how to save £500 million a year in ophthalmology alone. So, there are very big economic issues that we need to sort out, and we are trying to sort out, limited by legislation. But to me, this debate is about individuals and their perception of risk.
I would like to move on to the second question, which, should the same ethics apply? I think we've probably covered this, but let me just go through the question. We do same-day surgery in these other areas, refractive surgery, lid surgery, squint surgery, retinal detachment, and intravitreal injections.
I would say the same ethics apply, but the answers may be different in each case, because these are going to be fact-specific issues.
I think from an ethical point of view, regarding a lot of these cases, the risk is not as catastrophic. I think that's the unique thing about eye surgery. Even though it is slightly routine or considered routine in society, it's actually can have a catastrophic visual outcome. That's not quite as inherent in all the others. Also, cataracts are not an emergency. There's no time pressure on cataracts. So if you do them now or next week or next month or next year, the outcome's going to be the same. Whereas some of these conditions have to be done, there is a bit more of a time pressure on them. So I think they're not the same because the risk is, the harm is different level of harm.
So I'd say that laser refractive surgery is definitely a choice, a lifestyle choice, and it's not really sight-saving. And equally with bilateral intravitreal injections, there is a risk of bilateral endophthalmitis as well, which some people do. So 2 wrong doesn't make 1 right. But when I tried to put these questions together, I was just trying to highlight that there seems to be some irrational fear, which I'm really hoping that can be overcome, so that so people are not just so completely frightened by it.
As I said earlier, one of the difficulties with the AMD is the source of some of the therapies, and people of particular faiths will have to know, be informed about whether, for example, stem cells, what kind of stem cells are being used in some of these therapies.
And that's, in a sense, a separate point, isn't it?
But it's still an ethical point.
But it is a very important ethical point. I think the point here was that the injections are made on both eyes at the same time. Is that so?
But will doctors actually tell people this is what we're using? That's
very good question, and it's something where I think the consensus is we have to get a lot better at explaining these things and dealing with the issues that arise. So have we covered the second question satisfactorily? Then let's move on to the third one. What further evidence do we need?
John, do you want to take that one, John?
Well, yes. I mean, because of the rarity of the events, it wouldn't be possible to prospectively start doing a trial to determine the safety of this procedure or the risk of that. So the only way evidence can come is retrospectively looking at countries who are doing it. So fortunately, Canada, Finland, parts of Sweden, Norway, the Canary Islands, there are countries around the world who are doing this. So someone has published a case series of 100,000 same-day cataracts. So 100,000 people had the same day, and there was a dozen patients, slightly more, who had an infection in one eye, but there was no patient who had an infection in both eyes. So that's the sort of level of evidence that you're likely to get, but that's only 100,000 patients. We almost need 100 million patients to really tell us what the risk is of having bilateral infections. And the other thing we don't know is what's the risk of bilateral infection if you have them on different days. So if we have one eye done this month and the next eye done in November, of the group of patients who do go blind in one eye from their first operation, and those people exist, most of those will be developing cataract in their other eye, and a lot of them will at some point opt to have surgery for that with trepidation, but they will experience the same percentage risk, and therefore there will be people around who have gone blind in both eyes from infection in one eye, infection in the other eye, who had them on different days. So it's not that we're conjuring up a new group of patients who've gone blind in both eyes. It's just the fact that we are not allowing them to go blind on separate days. We're causing it to occur on the same day by the choice to offer them that.
Can I just respond to that? I agree with you, actually, but what we've also got to bear in mind is the person who has the bilateral blind patient is never going to publish it. And one of the problems you have with published data is it's the good results that people get out to publish. That's one thing. Yeah. And secondly, the individual who loses their first eye then has the choice to decide at what point they want to risk their second eye. So I can see both ways, but I just thought I'd better put the counter-arguments because it is not easy to weigh it up. You could make arguments in both directions.
Thank you. I mean, that it comes back down again to the assessment of risk being a patient matter, really.
I sort of read this as being slightly presuming in favour of but immediately sequential bilateral surgery. So I think one way. So I wasn't entirely clear on the interpretation of the question, but I think if we do get sufficient evidence to show that it is as good, if not better, then that seems to speak quite strongly in favour of offering it as an option to patients. That didn't seem to be. However, that relies on our answers to questions 2 and 3 very, very strongly, and I think we have to have a much stronger evidence base. but that's not my area of research, so I couldn't comment on how that would go about. I can, I think it quite closely relates to what Bertie was saying previously about giving patients a choice. I think they have to be allowed to decline it. That seems to be a fairly straightforward question.
Legal.
Yeah, legally, it's question B, as we've already talked about, is a little bit more complex, but that comes down to a broader question of distributive justice more broadly, rather than an ethical question in surgery, and I think that might be slightly beyond the realm of this debate, but I don't know what others in the ethics bracket might feel about that.
I mean, to question number 4, should IVS prove to be overall better? I think I've nailed my colours to the mast. I think there is a social justice upon doctors in the healthcare system to try and produce the most efficient model possible, because it's not an endless resource. It is a set sum that we are distributing upon different claims for that resource. So I think, for me, if it's exactly the same, if evidence is there, then yes, I think it's something we should be moving certain patients to provide it for certain patients. Obviously with all the caveats in, but the rub is, and this is the rub, how much risk do we take for the cost?
Yes, please go.
Possibly on this point as well, the risk question is relevant to consider, I think, the health economics of each procedure, but for the individual patient for whom it goes wrong, you can't go, but we save 30 million quid a year for other people, because that's still catastrophic for them, and that's probably not going to be terribly comforting, and something that I don't think that we can compare, or is far less commensurable, perhaps is a way of putting it. It's not going to help them, it's not going to improve their life, and I think that is a very relevant consideration. If you're a utilitarian, then that's possibly fine, but I think we need to be careful if we're going to become a utilitarian in that perspective. So. Well, I have friends and colleagues who are utilitarians, and they'll be like, yeah, that's fine, don't worry about it. They work in very theoretical philosophy. I have other friends who, I have others who are utilitarian and work with patients a lot more and would be much more hesitant about that. Equally, I have deontological colleagues who would go completely the other way, and it doesn't matter. So,
if you show a child who's been saved from cancer, it might help.
Yeah, it's a much more fraught question. It's a very fraught question, but I think it's very difficult to say, well, we saved this child. You should have gone blind because it allowed us to save this child from cancer. I'm not sure I would know how to comfort a person. You know. But again, but again, it comes down to this deontological or utilitarian ethic that you want to adopt, and that's very, very challenging. And I also think that I don't think that you can reasonably say to somebody who has had a very severe harm inflicted upon them, tough luck, but we made the decision. Well, you probably have to in health policy, but morally speaking, that's I think a very difficult conversation to justify, and a very difficult one to do. Theoretically. Accidents happen.
Ban cars, so that would save 12 people a day.
Yeah. Probably more, but yeah.
I'm moving on to question 5. I don't think we can be any doubt that one of the major things that we've been saying all the way through this is yes, absolutely, to question 5. And in fact, I would add, should surgeons be given the choice to that as well? Because from our colleagues around the table, I think surgeons clearly do not want to be, and in fact aren't allowed to be obliged to do an operation of any kind. So, but the patient has to be given choice, clearly. And with appropriate caveats and explanations and everything else. But I think that, I mean, the nature of the NHS is nothing about me without me, isn't it? I mean, that's so you can't just impose a surgery or anything on anybody.
I think you wanted just to make a point.
I feel that a lot of these questions can be answered easily if we have more evidence, more systematic. I can see the point where, you know, the research is based on selective cases, on successful cases. That shouldn't be the way. And I believe that whatever we have today, whatever evidence, even if it was on a smaller population of patients, that should be presented as evidence. And then when we have more, then we should modify that into whatever we found, the more recent studies. And I'm sort of hoping that there will be like an application where you could put the data in it, and then you can calculate the risk, which, you know, nowadays you have it in the NHS. They, you know, your age, blood pressure, and your habits, and they say you have 10% chance of having a heart attack in the next 10 years. So, you know, something like that is, and there are many students, you know, and these statistics is not something, you know, in telecoms, it's all about statistics, because it's not, you know, it's digits being sent, and then you can only predict what will come next. And I think we must have evidence. And this evidence, whatever we have today, should be put in a form that can be presented to both the consultant and to the patient. And then when we have more evidence, then we present the more updated evidence.
I think Christopher would like to respond to that.
So actually we do have risk stratification, so we can tell patients in their particular case what the risks are to them. So it's not as though we don't know, because based on the work of these hundreds of thousands of patients and their outcome, we do know which are the riskier patients.
Okay.
Thank you. Can we move on to the question about correct information? How do we ensure patients receive correct information? And all the associated things there. Ethical for surgeons to decide for themselves without giving the option. Ethical to...
Certainly from an ethical point of view, is it ethical for surgeons to decide themselves without giving this option to the patients? I think we're covering that now with informed consent, aren't we, really? From what my learned friends have told me over there, is that it's now going to become more pressing on us as doctors not to just give them a sheet to sign on the day, but to give them a full, you know, videos or apps, I think he was talking about, for people to be more fully informed. So I think that's a no. I think we should be informing patients of all options. Yeah. I think that's my ethical stand on that.
Just responding to this, I think that the whole idea of the question is, in our practice, sometimes we just don't mention bilateral as an option to our patients. So are we justified to just take it as granted that it's a one-eye surgery, or we have to mention this to the patient and respond to their questions and yeah.
Yes,
I think the law would expect you to set out the alternatives for that patient and set out the risks and benefits for that patient, including the option of no treatment. So I think that we haven't really discussed that around the table, but that's certainly what the law would expect you to do. You know, and obviously in many respects within medicine, if you think that a particular procedure is suitable for the patient, but you can't supply that procedure within your hospital, and you have to explain that to the patient as part of the discussion, saying, well, I can't supply that to you. I think it's clinically suitable for you because, and you have that whole discussion with your patient, but you then go on to have the discussion to say how that patient could access that procedure if they so wanted to, and that's all part of the informed consent process. And just coming back to you on the consent form, I do agree absolutely with Bertie, and I've heard many barristers say this, and lawyers, that the consent form is a piece of paper that the patient signs. Nothing more. Nothing more.
My understanding in terms of these days of material risk is that the patient should be offered all reasonable and valid options, including those that are, if you like, less ideal, the alternative options. So that's why we have to have that discussion with, say, cataract patients. You know, we do nothing, we could refract you, etc. So we could give you, if you look at the shared decision-making tool from Right Care, it actually includes offer the patient low vision aids. Now, you might think that's laughable, but that's an option. Now, to me, this is a realistic and valid option, which some patients might not wish, but it is an option, and I think to withhold it is incorrect. If you look at the case that led to the sort of material, the Montgomery case, I think it was about that lady not being offered, I think, the option of the caesarean section. I think this is the same. We may consider it higher risk, but it is for the patient to decide, and I would say it is right thing to do to make the offer.
So have we covered that question sufficiently? If we have, let's... The unconscious bias one, you'd like to come back on that?
Yeah,
yes.
that's okay.
Yes, of course.
It's more a structural question, a point about the question itself rather than a response to it, but I'm not sure that we can say that unconscious bias coming out, the point is that it's unconscious, so that you can't be held responsible for something that you're not consciously doing, I think, or that there needs to be something that's in there to make people aware of their unconscious biases rather than I'm not sure how you would adjudicate, well, you were unconsciously biased at that point, because I don't know, I was unconscious about it. So I think that we need to, if there's something there, then there needs to be some training on, be aware of where you are and make it clear and be very definite in your statement so that they're not passed poorly or they're not articulated poorly.
Yes, it comes down to, I guess, developing the methodology of the consent process and documenting that.
Just coming to the second part of that, where it says, equally, is it ethical for surgeons to decide on behalf of their patients that a small risk of bilateral blindness for individuals is worth extrapolating that? I suppose at the minute we default to only eyes. We default, like we just do one eye. I suppose would the default be, if we were to say the default was we're going to operate on you bilaterally unless you opt out? You know, we're saying at what point does the patient opt in or opt out? What's our, you know, at this hospital, yeah, our default is we do both eyes, we do bilateral cataract, and the patient has to opt out of it. It's like it's a slightly different angling of it, and I think that's something that you need to think about.
And that carries unconscious bias with it as well.
Yeah, exactly.
The authority of the hospital has a significant impact on patient interpretation.
And again, there's going to be a health service bias in that. So ethically, I think that's have them both mentioned and let the patient decide. That's the way of jumping out of that one. Unless the health service feels it's so cost effective that it's worth having it as the default for most people, unless you are, you know, unless the caveats kick in.
Thank you for that, and it's something I think to give some thought to. So coming on to the next question.
Who's supposed to be rational here? You know, is it rational? Are we talking about the patient, in which case we've already talked about benefits and material benefits mean different things to different people, so it's a funnily worded kind of question.
It's a loaded question.
Yeah.
I think it's a very useful question, because the discussion from my learned colleagues say there's a whole lot more risks and things that are involved in this, and not just, you know, I can't pronounce the word, endothermiasis or whatever it is. So I'm not sure it's a terribly useful question in general.
Christopher, can I point? I think there probably are other risks. So, you know, you could have bilateral retinal detachments post-surgery if you're unlucky. I guess if there was a contaminated or toxic fluid back, you might get some horrible toxic anterior. So there are other things. One of the other things I think that isn't on the list that has been on my mind when I have this discussion with patients is particularly where you might have an elderly patient and they might actually have a lower severity complication, and it might be something that resolves. But so, for instance, excessive inflammation in the eye or raised pressure, they have to start coming back to the clinic, they have to start using drops, perhaps the vision's a bit blurred in the eyes. And if that's in one eye, you know, they can concentrate on the one eye, they still have the other eye potentially to see. Having two eyes on the go with different regimes of drops and both perhaps a bit blurred, it's just a practicality thing. It can be quite unpleasant and difficult for the patient to deal with.
So for older people, it can be overwhelming. But just going back to contaminated fluids, because each eye would receive completely different fluids, I think that's unlikely. And as for retinal detachments, it can happen any time from several months to a year or two. So having it on the same day or separate days doesn't really make any difference. But I accept that I think it could be overwhelming for some individuals if things should even go slightly wrong.
Yeah.
So in conclusion, what are we saying on that one?
I think it's informed consent and patient choice. And
patients are allowed to make unwise choices, so you can make a comment about whether it's rational or not, it's the patient's choice.
Indeed. The questions are sometimes deliberately provocative. Yes.
Never worked that out.
Fine. I think we have reached the end of that one. So can we move on to question on the balance of the interest of the individual? We discussed this to some extent already. Public health and societal interests, and should the public call the tune? And how do we reconcile the good for the many and the harm to the tiniest minority?
I can suggest the Clinical Council for Eye Health has put together the SAFE system for assured framework, which deals with a lot of these issues, which is already a framework extant out there for which you can work these things out. So I think there is actually a framework to use, which, so in a way, putting it all together again would be a bit like reinventing the wheel in a sense. So it's worth referring to that, I think, on that in that context.
That sounds very sensible.
It's now trying to find how much of this deontological utilitarian battle, where does the individual trump society and society trump the individual in a closed pot, limited resource setting? And that's a very tough question.
Certainly the Christian tradition would obviously make a difference between doing direct harm to someone and, you know, collateral damage, which I think is generally what we're talking about. And obviously the Western Christian traditions and the medical, you know, ethics and promise, you know, you can never do direct harm to anyone, particularly the weak. That is against the nature of what goodness means, and you know, in our tradition.
And then moving on to the next element, between being safe with more higher cost and discomfort, and saving money and being more comfortable with higher risk. How do we determine the level of risk that we should not exceed for any operation?
I was thinking that. There's another view of the same question.
Yeah, it's an extension of that question.
True, but I think they can answer it.
Yeah.
They are capable.
I always remember when I was reading about, there's another ophthalmology guilty this a few times, is there's an injection for macular degeneration, and there's two drugs available. One is one's got called Lucentis, one is called bevacizumab or Avastin, and one is really, really cheap, one's really, really expensive. And when you do a health economics test on it, you could have someone die as a side effect of the Avastin. That if you used a quality measure, you could have someone die from using the Avastin, and it would still be more cost effective from a health point of view, from a health economics point of view, than the more expensive drug. However, it's distasteful to think that someone would kill somebody. So I think it's putting that economic argument into a little bit of deontological, that bit of taste there's only so much harm that we'll accept for cost. Where that sits, I think, I don't know what NICE is now per year, per quality year, is it £20,000?
For a common condition, I think it's £20,000.
£20,000, yeah. So that's the economic argument there. From a moral perspective, I think we've got the weak, you know, there's certain moral caveats. People live, you know, just desserts, that kind of thing. So, sorry, so please.
Did you? No, it's I was doing the thing again of going, I've got a question about the question, I'm afraid. But I think one of, as we've been talking about all afternoon, the key point is how do individual patients measure that? And so the option A is little more safety with higher cost and discomfort. That's possibly preferable to the patient 1, and option B is preferable to patient 2. And I think, like you're saying, we have the nice guidelines as it's an extension of the previous question, I think, and we have these guidelines that are in place to do that. But the patient has to be at the centre of those decisions. They have to be, and they have to get full guidance, because they're the ones who get to decide what they count as discomfort. Because patient 1 may think that actually I'd much rather have the spacing and the rest of it, whereas patient 2, that's inconceivably inconvenient and uncomfortable, so that's not suitable. So I think this, with as a previous question, with an emphasis on the patient involvement, has to be central.
Argument, because this is not just there's an argument for, say, a different comparison where you have 2 treatments, and one of which is perhaps slightly more risky but is going to save the NHS money, and that's a sort of fairly, you know, if you like, almost for society and the public to decide. But what we're talking about is something that also offers a benefit potentially to some patients. So we're not just sort of making a choice about, look, we can do more care, we can make NHS resources go further if we do this slightly risky case. Actually, if we do something that we think may be slightly riskier, but it actually has benefits for that individual patient, I think that's a very different question and less morally uncomfortable than, say, something like Avastin, which I guess is, I'm not so worried about fatalities from which I think are unlikely, but there may be a higher risk of sterile endophthalmitis, as your favourite word, Matt. Infection is much easier to say. You know, we would choose that drug purely because of cost, but it may have risks. That I think would be an uncomfortable decision to make for sort of hopefully caring clinical people. But where there's that benefit for that particular patient, then that patient balances that benefit for them against that risk. It's a better and easier decision, I think, to be faced with.
So just to rephrase that, it's not purely an economic consideration, that there are benefits in bilateral for some patients.
Yes.
Thank you.
Do we not feel, though, that economic issues, even in isolation, are still a social justice issue, given the fixed pot of money that we have? Because as has been said, when the money is not there, the services stop. And who is disadvantaged first? It is inevitably those at the bottom end of society in terms of their ability to access things. So although we won't see the faces of the people who are denied treatment by our inefficient use of resources, they still have faces, and they still have names, and they still have stories. So we have this person in front of us with a face and a name who has suffered bilateral blindness on the same day, but we have saved countless other people who have neither faces nor names that we're aware of, but they are likely to come from the weaker section of society. So for me, I am happy to be labelled a utilitarian, but I don't see it as that, because I see it as a social justice issue, that we use the finite resources we have most appropriately. And in this instance, I think there's a strong argument for at least exploring this option. And yeah.
When this patient sits in front of you, he has trusted his sight in your hands. And he believes that what you're telling him is because you care for him now, and is in his utmost best interest. If the decision is biased by helping someone else, you have his trust in you has been, you've used someone's trust for something you're not providing to him. So if you're the health minister, he knows that that's the decision. When you tell him we're going to do this or that, it's because the health minister is caring for everybody, so you haven't done him wrong. But when he comes to you as his doctor, he trusts that you are my advocate now, and you're looking for the best chance for me to get out of this with my full sight. And if there's something in that decision-making process that's because someone else somewhere will not die, you've misused his trust.
No, I agree totally, yeah.
But the decision has to be made higher up, doesn't it?
That's something else, but that's not the doctor's job.
But we only
Part of what we suffer from me as an advocate is because doctors somehow understand that they're caring for the system. We want doctors that fight for the individual patient, and someone higher up telling them, you're right, but we can't do it because we care for the system. When you have a doctor who starts to explain to the patient, I'm not sure I should do that because I care for the system, he has stopped caring for the patient and is caring for the NHS budget. That's not his job.
But already there are some health trusts on the issue of Avastin where they are saying to patients, we have this unlicensed drug, it is cheaper. We can offer it to you, you will be saving the health service money if you choose to take it, but it's your choice. So already that sort of thing is being offered to patients. So,
Or they're making prescriptions harder to get, and there's all sorts of inactions.
So I just want to say that obviously if we have something which is better and less expensive, then the answer is very obvious. But also I think as a doctor, of course our first responsibility is to the patient in front of us. But also we also have a higher responsibility in terms of public health when there are no particular patients in front of us.
I think it's worth noting that one of the good duties of a doctor under the GMC, good medical practice, is a conservation of resources. So actually that is now one of our duties, so we do have to balance that up with the individual patients. I think the other way of potentially perhaps thinking about this is if we have a treatment that we think is better and more cost effective, and it is not, from the data we have so far, less safe, what about thinking about it that way? Rather than saying we think it might be more risky, we could flip it around and say we have no evidence that it is less safe. All we can say is that should it go wrong, the consequence may be more devastating. That may change minds slightly.
If I do want an honest opinion, what's best for me? Am I supposed to go for a private opinion? Because that's the only way I will get the doctor telling me what's best for me, because it's the doctor's duty to take care of the economics of healthcare overall.
I don't think that's a good one, no.
I think when you're seeing a doctor one-to-one, you can be sure that any decent doctor will be...
I'm taking it to the far extreme.
But at the moment, we're not seeing patients. Not at the moment.
Well, that was an interesting angle to complete that one on. We are running slightly over time. We have one further question on the list, which I'd just like to air with you as well. Given the improved safety of cataract surgery, should ISBCS remain a taboo subject? And if not, how do we destigmatize it?
Or is it bad again? Another bad question.
No, I'm not sure it's an ethical question.
What is it then? What question is it?
How do we destigmatize it? That seems to be a complex question.
Oh, okay. Dr. Husni?
I think simply by offering it more. If we believe that it works, at least some of us do, we'll offer it more. And then we'll offer it more. And ultimately, the stigma will go away or will be minimized. Anything new, this is the thing, from the dawn of man's history, anything new is resisted. We know that for sure. Even if you go 10 years, 20 years ago, people resisted to all sorts of things. Mobile phones, WhatsApp, I resisted it for many years until I thought myself in an island on my own, so I just went for it. Okay, there are restrictions to anything, but this is something new, and in my opinion, I don't want to say revolution, maybe it's less than revolution, but it is something new. It is something which can offer more comfort for the many rather than for every single person. It is an option at the moment, and I think we need to use it more. And the more evidence we have, ultimately we'll have more evidence of this procedure being a very good procedure or maybe not that good. So ultimately we will just do more and more until we either go ahead with it or we just U-turn. But at the moment, I don't believe there is any catastrophic results to suggest that, wow, don't do it, or it's a dangerous thing to do. I haven't heard that around the table, to be honest with you, as someone who is not in the midst of the medical profession. I haven't heard anything to suggest that, there is something very, very dangerous about it. Not at all. To the contrary, all the statistics so far, albeit from other countries, suggest that maybe there are benefits, maybe there are things to be gained for the individuals, for the for the surgeons, for the health service, for the country, etc. So let's just not care about this stigma. Do more of it. Congratulations for those who uphold it and defend it, continue with it if it is not illegal, show what results you have, be honest, and we know that we are all honest, until we give it more strength or cause it to a stop at a certain stage.
Thank you very much. I think that was quite a valuable summary of perhaps where we are. What I'd like to do is just finally just to go around the table and ask if there are any other, if there's any other business, if there are any other points that anyone around the table would like to raise. We're at 5:45, so we've slightly overrun, and I don't normally expect to overrun, but I think it's been very important to have sufficient time for this to get as far as we can. So can I quickly ask you around, Peter, did you have anything? Chris?
No, I think that's been a very positive meeting. I think ethically we've raised some very good points, and I think now it's just trying to overcome professional inertia.
Thank you.
I would just back that up. I think the ethics have been very interesting to actually discuss that and actually move things forward in that way. I think the economic arguments are equally interesting. There's an awful lot to debate in this that when you first come into it you might not necessarily see, but from a patient and patient representative point of view, I think it's there's certainly options that go around, and I think for certain bits of the community which I talk to, it would be incredibly useful, incredibly valid to do this exact procedure, but potentially not for everybody. But we'll have to, I think, as we move on, exactly as you said, we'll see how it goes as the situation changes.
And I think that's, if you think about the major advances we had in living memory, the introduction of the intraocular lens and the introduction of small incision phacoemulsification surgery, in both of those cases there was an initial risk and people were very wary, and it was only by doing them and working through that and showing in the end it was beneficial that we got there. So I think that's it, it's a pragmatic approach.
From this fruitful discussion, we have identified some areas of research, and will be very useful to put it down as written that we need to do this research about bilateral cataract and compare it to the standard of care and see, identify those areas and encourage people to add other areas of research so that we can end up with a good conclusion in the few coming years. Yeah.
Thank you. I just want to thank everybody for your time, but I might say that right at the end.
Thank you, Benji. I too, just if I hand back to Christopher, I would like to say thank you very much for contributing so much. I apologise for being slightly later than time, but I think it's been time well spent. There's clearly quite a lot of development of some of what's been discussed here to undertake, to develop, and I'm sure the debate will go on. Christopher?
So there are no questions on this side of the table. Have you all been given an opportunity to say final words? Are you all right on this side? Well then, I just like to thank everybody for coming and putting up with the terrible questions, and for George for chairing the impartial part. That's all. Have a safe journey home.